Hello, 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 NCLEX Crusaders, how are you? Welcome. Another live training. Let me know if you can hear me and if you can see the presentation, please. All right, just waiting for confirmation. Yes, Mayra, yes, very good. All right, excellent, excellent. All right, let's just wait a few minutes for everyone to connect so we can begin. Hi, Alex, how are you? All right. All right, let's begin. Let's start today's training. All right, all right. Hopefully this camera starts working properly today. It's been showing off, acting off. All right. Welcome everyone to day number 13. We have been doing these live trainings for 13 days already. And you know, the focus of our live trainings on YouTube at NCLEX Crusade International is to teach you and show you how to pass the NCLEX successfully. So if you are a nursing student, if you're preparing for the NCLEX, I want to give you a warm welcome to NCLEX Crusade International. If you're new here, make sure you're subscribed to the channel, activate the bell so you don't miss any of the information. Okay, if you're new, comment in the the comment section that you are new and where are you connecting from. As you know, we always have a question to practice for the live training. The purpose of tonight's training is going to be about cardioversion, supraventricular tachycardia, but as always, I like to share some other content information. So today we're going to discuss sinus tachycardia, SVT, supraventricular tachycardia, ventricular fibrillation, and cardioversion, synchronized cardioversion, and defibrillation. Okay, so that's going to be the topic of today's training. Here's the question that we're going to be discussing at the end. I'll give you the answer at the end of the training. So the question is very basic. The nurse is assisting during a scheduled cardioversion for a client who is experiencing a supraventricular tachycardia. It would require follow-up if the nurse, and then you have the four answers. So several things to keep in mind. Several things to keep in mind in here. The cardioversion is scheduled, and then the patient is experiencing SVT, supraventricular tachycardia. Then the most important detail of this question, it says it would require follow-up if the nurse did one of these four answers. So the first thing that I want you to think about is this a positive or is this a negative question? Okay, so that's going to be the topic of today's training. Okay, Richa taking the NCLEX on the 14th. Wow. Valentine's Day. It's going to be a nice day to take the NCLEX. I'm new for the live training, following your videos on YouTube. Welcome. Okay, so somebody's asking, does this mean, Professor, that I am looking for something the nurse did wrong? Is this a negative question? Absolutely. I'm looking for something the nurse did wrong. Okay? But we will discuss the question at the end of today's live. So what is sinus tachycardia? Let's begin with that. Although the question is about SVT, let's discuss sinus tachycardia first. So sinus tachycardia, as you can see on the EKG strip, is a regular cardiac rhythm that occurs when the sinus node, when the SA node creates an impulse at a faster than normal rate. In other words, in an adult, a patient who has a heart rate above 100. We discussed on a previous training what the SA node is, the normal electrical functioning of the heart, how the electrical current goes from the SA node to the AV node and then to the rest of the heart. If you don't know what I'm talking about, find the YouTube training that we did live a few days ago where we discussed this specific topic. But if we look at the strip, we're going to notice that the rhythm is regular. So the first thing you got to know about a sinus tachycardia is that it is a regular rhythm. So what is the difference between a sinus tachycardia and normal sinus rhythm? The only difference is that the heart rate is above 100 because everything else is the same. The rhythm is regular, there is a normal PR interval, there is a normal QRS interval, there is a P for every QRS, so it is exactly the same. The only difference is that the heart rate is above 100. What could be some of the causes? What can cause sinus tachycardia? Well, it could be due to a physiologic or psychological stress. Physiological wise, acute blood loss, anemia, shock. We were talking about shock yesterday. Hypervolemia, hypovolemia. We're going to talk about those two conditions on another live training. Heart failure. We're going to talk about that condition in another live training as well. But all of these physiological conditions can put the patient in sinus tachycardia. Also, fever, exercise, and psychological wise, even anxiety can put a patient in sinus tachycardia. But also certain medications that stimulate the sympathetic response can also cause sinus tachycardia. For example, catecholamines, aminophylline, atropine. We talked about this medication the other day as well. Stimulants such as caffeine, nicotine, alcohol, illicit drugs, amphetamines, cocaine, ecstasy. These medications or drugs can cause sinus tachycardia. Now, what do we do if we find a patient with sinus tachycardia? What is the treatment? Well, just to cover a little bit the thinking process of a patient that has sinus tachycardia, what will we do for them? Technically, we treat them if they are asymptomatic. If they are symptomatic, okay? So if they're showing symptoms, they're showing a hemodynamic compromise, then we have to treat the symptoms. And most important, we need to identify the underlying cause of the tachycardia. What do I mean by this? What do you mean by this, Professor Ray? Well, let's say your patient, when you put them on a monitor, they have sinus tachycardia, but they have a fever. So how do you treat the sinus tachycardia? Take care of the fever. Administer an antipyretic drug. What if the patient is in severe pain and has sinus tachycardia? How do you treat that sinus tachycardia? Give medications for pain. Okay? So you have to treat the underlying condition. What if the problem is hypovolemia? How do you take care of the compensatory tachycardia? Well, treat the hypovolemia issue and the tachycardia will resume, will stop. So you have to identify the underlying cause, the underlying reason, treat that underlying reason. Does that make sense? Is this making sense to you? Very good. Now, let's go and discuss supraventricular tachycardia, otherwise known as SVT. And SVT, supraventricular tachycardia, is a very, very fast rhythm. Okay? As you can see in the image, we're going to see a heart rate that is way faster than what we saw on a sinus tachycardia. Okay? And another thing that we can visualize is that we do not see the presence of a P wave. Why? Why we don't see the P wave? The rhythm is going so fast that the P wave is hidden and not visible in an EKG. When we look at this rhythm, we're going to identify that we're going to see a QRS complex that is going to be between 0.6 and 0.10. 0.10. Now, what is the treatment of supraventricular tachycardia? And that is the main focus of today's training. How do we treat a patient that has SVT, supraventricular tachycardia? Well, one of the first interventions is the carotid sinus massage. Remember that the right common carotid artery splits into the right external carotid artery and the right internal carotid artery. We can see in this image, the practitioner finds what is known as the carotid sinus. That's why this is called carotid sinus massage. So the practitioner finds the carotid sinus and starts massaging this sinus, this area. By massaging this area, by stimulating the carotid sinus, it's basically going to trigger an effect. It's going to cause an effect. It's going to trigger the baroreceptor reflex. And it's also going to increase the vagal tone. What's going to be the outcome of this? It's going to affect the SA node and the AV node. So during this treatment, when the baroreceptors are stimulated, it's going to determine a neurochemical process that is going to explain the vagal maneuver. This vagal maneuver will slow the heart rate and the blood pressure through a parasympathetic response. So we're going to see the effect of certain vasodilators like bradykines doing the effect on the heart and decreasing the heart rate. So this is a treatment for SVT. Now this treatment is done, the carotid sinus massage is performed by a healthcare provider. This is not something a registered nurse is going to do. So what are the steps? Basically, the healthcare provider instructs the client to turn the head away from the side in order to be massaged. Okay, so positioning the patient. Step number one. Step number two, the healthcare provider is going to massage one side of the carotid artery for a few seconds. And then, by putting the patient in a cardiac monitor, the practitioner is going to monitor the EKG, the cardiac monitor, in order to find if there is a change in the cardiac rhythm. In other words, did it convert from SVT to a normal sinus rhythm? So it's very important that the patient is being monitored on a cardiac monitor continuously. All right, an EKG strip is collected before, during, and after the procedure to compare. So step number 3 is important. And step number 4, we need to have the emergency cart at the bedside. We need to have a defibrillator. We need to have any equipment that is necessary to perform CPR. We're going to monitor vital signs, cardiac rhythm, level of consciousness following the procedure. So here you can see the steps that needs to be completed for a carotid sinus massage. Okay, so what is another intervention that can be done in a patient that has SVT? Well, we have the Valsalva maneuver. Okay, the Valsalva maneuver, basically the healthcare provider instructs the client to bear down. That increases the intra-abdominal pressure and stimulates a vagal response. Another way that the Valsalva maneuver can be done is by stimulating or inducing the gag reflex. Either doing the gag reflex or the bear down is going to both stimulate a vagal response, and at the end is going to do the same effect. Reduce the heart frequency, reduce the heart rate. We have to do pretty much the same. Monitor the heart rate, monitor the rhythm, blood pressure, observe the patient on a cardiac monitor. We have to do the EKG before, during, and after. And in this case, we have to provide the patient with an emesis basin if we are stimulating the gag reflex, because that can make the patient throw up. And we have to be careful, institute aspiration precaution. And of course, we need to have the defibrillator and resuscitative equipment at the bedside. Now, what if a patient is on SVT, we've tried the Valsalva maneuver, a doctor has done the carotid sinus massage, no change in rhythm? What is another intervention that we can do? Well, we can try a pharmacological intervention. The medication of choice for a supraventricular tachycardia is adenosine. Adenosine is administered rapidly, fast, over 1 to 3 seconds. Usually the first dose is 6 milligrams. And why is adenosine administered fast? Who can tell me? Do you know why? Do you know why we administer adenosine fast? Why? Why not slow? What do you think? It's administered fast because adenosine has a short half-life. So the effect of the medication is very slow. Okay? The effect is very short. So we need to administer fast to do its effect, and very quick. If the medication is effective, we're going to see a change in the rhythm. We're going to see a conversion from SVT to hopefully normal sinus rhythm. Now, what if we administer the first dose, we administer the 6 milligrams of adenosine, and the patient does not convert back to normal sinus rhythm? What if we administer the medication and the patient does not come out of the SVT? Well, we can administer a second dose. So the first dose was 6 milligrams. The second dose is double the dose, multiply by 2, 12 milligram dose. And it's going to be administered in a very similar fashion, the same way. So quickly, if the patient does not convert from SVT after the second administration of adenosine, then we have to try something else. Other medications can be used, such as calcium channel blockers, prokinamide, amiodarone, but the first medication choice is adenosine. So notice, we're going from least invasive to more invasive. First, the carotid sinus massage, Valsalva maneuver, wasn't effective. Then we tried the adenosine pharmacological intervention, not effective. Then we have to try synchronized cardioversion. Now, do not confuse synchronized cardioversion with defibrillation. Okay? It's totally different. One thing is synchronized cardioversion, another thing is defibrillation. Well, we're gonna discuss the differences in today's live. So what is synchronized cardioversion? It's a cardioversion that is synchronized, right? That makes a whole lot of sense. A cardioversion that is synchronized countershock basically helps to convert an undesirable rhythm, such as SVT, into a stable rhythm, such as normal sinus rhythm. Now, interesting enough, the cardioversion can be an elective procedure or can be an emergent procedure. So, it can be something that is scheduled, or it can be something that needs to be done in an emergency. Either way, the purpose of the treatment is the same: conversion from SVT. Basically, an elective procedure for SVT is more done on patients that have stable tachydysrhythmias. Whether an emergent procedure is usually done, an emergent synchronized cardioversion is done on patients that have SVT, but they are hemodynamically unstable. Okay? Recall that a lower amount of energy is used in synchronized cardioversion in comparison to defibrillation. The cardioversion is synchronized. What does that mean? What does synchronized cardioversion mean? Is synchronized with what? Do you know? Do you recall what synchronized cardioversion means? Who can tell me? Who can tell me in the chat? In the chat. So who can tell me in the chat why it's called synchronized cardioversion? All right. It's called synchronized cardioversion because it is synchronized to the R wave. It's synchronized to the R wave. Why is it synchronized to the R wave? Because if it's not synchronized, the countershock could be done in the vulnerable period of electrical cardiac activity, which is on the T wave. If while doing the cardioversion, if it's not synchronized, it's done on top of the T wave, is going to cause something known as the R on T phenomenon. What is the R on T phenomenon? It's basically when the shock is delivered on top of the T wave. And what's wrong with that? What's the problem with that? It can put my patient into deadly dysrhythmia, such as ventricular fibrillation. So yeah, the patient is in SVT, but if we don't do it synchronized, we can send the patient to a ventricular fibrillation, which is worse. So here you can see the R on T phenomenon. We can see that the R on T phenomenon means that a PVC, a premature ventricular contraction, or an unsynchronized cardioversion lands on top of the T wave, which is the vulnerable period, precipitating the patient and sending the patient to a ventricular fibrillation. So we're trying to avoid the R on T phenomenon. So that is why it is done synchronized. Okay? Let's go to the next one. What is ventricular tachycardia? Notice we've gone from bad to pretty bad. So from sinus tachycardia to SVT, supraventricular tachycardia, and now we are at ventricular tachycardia. What is ventricular tachycardia? Occurs because of repetitive firing of an irritable ventricular ectopic focus at a rate of 140 to 250 per minute. It could be seen as a 3 self-limiting beats or more. It could be sustained or not sustained. It could be a run of V-Tach. And it looks like this. This is one of the presentations. As you can see, there is no P wave. We have a wide and bizarre repetitive QRS complex. Or it can present like this, which is known as torsade points. Either of these presentations are ventricular tachycardia. It's recognized as ventricular tachycardia. Now, there is something known as stable ventricular tachycardia and unstable ventricular tachycardia. Can you recall what is going on with the patient to be stable ventricular tachycardia, or what needs to be going on with the patient in order to be an unstable ventricular tachycardia? Can you comment that on the comment section? Because it's very important to know, because the interventions are different. The nursing intervention is going to be different if we are dealing with a stable V-Tach versus an unstable V-Tach. So let's discuss that. What is a stable ventricular tachycardia? It's a ventricular tachycardia with pulse. First point. V-Tach with pulse. And number two, no signs of symptoms of decreased cardiac output. So when you put the patient on a monitor, it shows a V-Tach rhythm, but then we check the pulse, and there is pulse, and the patient is not showing any signs and symptoms of decreased cardiac output. What are we going to do in those scenarios? What are the interventions? Administration of oxygen and administration of an antidysrhythmic medication. What is unstable ventricular tachycardia? Unstable ventricular tachycardia is a patient that is in V-Tach with pulse, but is showing signs and symptoms of decreased cardiac output. So now, in this scenario, the patient still has a pulse, but now is showing signs and symptoms of decreased cardiac output. What's the intervention? Administration of oxygen, antidysrhythmic drugs, and synchronized cardioversion. So the same synchronized cardioversion we saw in SVT, we can do it here. In a patient with V-Tach, with pulse, but with signs and symptoms of decreased cardiac output. Now, what is another way to see unstable V-Tach? It's known as pulseless ventricular tachycardia. It is a ventricular tachycardia without pulse. What are the interventions? Defibrillation and CPR. So remember, if your patient has pulseless V-Tach, the two interventions will be Defib and CPR. Remember, you only defibrillate in two cardiac conditions: pulseless V-Tach and ventricular fibrillation. The only two scenarios where you can do a defibrillation, not cardioversion, defibrillation. So I ask you a question. If you're on the NCLEX and they tell you in the scenario, a patient comes to the ER, the nurse puts the patient in a cardiac monitor, the patient is showing on the cardiac monitor ventricular tachycardia. What is the nurse's first action? What are you going to do first? 1, synchronized cardioversion. 2, defibrillation. 3, call the doctor. 4, check the pulse. What is the priority action? What is the number one action? Can you tell me? What do you think? What is the first action? Very interesting. Very interesting scenario. What are you going to do first? The first intervention, the first action is to check the pulse. Assess the pulse. Why? Why is checking the pulse my priority action? Because in order to identify what my treatment is going to be, I need to know if there is pulse or not. Because if there is pulse, I'm going to do the interventions of a patient with V-Tach and pulse. But if the patient has pulseless V-Tach, then I know it's my go-to will be defibrillation or CPR or both. So do not forget this. NCLEX tip. The number one priority in a client, in a patient with ventricular tachycardia is assessing the pulse. Lastly, let's cover ventricular fibrillation. So ventricular fibrillation is a chaotic, rapid rhythm. It's a chaos. The ventricles do not contract, they quiver. They do this. There is no pulse. There is no cardiac output. Ventricular fibrillation is fatal. The patient is dead. You're going to find your patient unconscious, no pulse, no BP, no respiration, no heart sounds, nothing. Your patient is dead. What are we going to do in ventricular fibrillation? V-Fib or CPR. So let's talk about defibrillation. Defibrillation is an asynchronous counter shock. First difference between defibrillation and cardioversion. Cardioversion is synchronized to the R. Defibrillation is asynchronized. It is used to terminate pulseless V-Tach and ventricular fibrillation. We talked about that. The defibrillator is charged to 120 to 200 joules if it's a biphasic defibrillator, or 360 joules if it's a monophasic defibrillator. So the patient will be shocked, and then CPR is continued approximately for 5 cycles or 2 minutes. After 2 minutes of CPR, we reassess the rhythm. If the patient is still in V-Fib or pulseless V-Tach, we do another defibrillation, okay? And continue CPR, resume CPR. We continue following the CPR protocol. 2 minutes, we check. No pulse, V-Fib, and continue CPR. A very important question that appears on the NCLEX on V-Fib, on defibrillation, is the use of pads. Remember that the pads are placed like this, as you see on the image. The top pad is going to be on the right of the sternum and below the clavicle. Remember, when we say right, we are referring to the anatomical position. When you're looking at it, it looks like on your left side, but we are referring to the anatomical position. The bottom pad is placed on the left side of the anterior axillary line between the 5th and the 6th intercostal space. Now, if we're dealing with a pediatric patient, especially if we're using an adult pad in a pediatric patient, then we're going to put one pad on the front and the middle between the nipples, and then one pad on the middle of the back. Remember this. Make sure that as we are going to defibrillate, no one is touching the patient, no one is touching the bed or anything near the patient's body. So it is important that the nurse that is going to defibrillate say, I am clear, you're clear, everybody's clear, and everybody needs to respond. Clear, 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 clear. Shock. Because if we're touching the patient, we're touching the bed, we could be the next one defibrillated and on the ground. So now that we know the difference between sinus tachycardia, supraventricular tachycardia, ventricular tachycardia, pulseless and with a pulse, and ventricular fibrillation, and you know the difference between synchronized cardioversion and defibrillation, you can answer this question and be sure about your answer. it will require the nurse to follow up in cardioversion. So we're talking about synchronized cardioversion. A patient is experiencing supraventricular tachycardia, but apparently is stable because it's a scheduled procedure. So what is wrong? Number one, administer one-time dose of midazolam. This is okay. Remember that this is a non-emergent cardioversion. The patient is hemodynamically stable. We can use a sedative such as midazolam to help the patient comfort. Remember, this is a procedure that a patient is going to be very anxious. They're going to be shocked. So midazolam helps to calm them down. There's nothing wrong with answer number one. I don't need to follow up. I don't need to intervene. So if you know the answer, put your answer on the chat. I want to see your answers. I want to see what your thinking is. You know that one is not the answer, but what is the answer? Okay? So let's analyze answer number two. Have you liked the video yet? Have you liked this training yet? Have you subscribed to our YouTube channel? I don't know. I only see 49 likes and there's 103 of you here. I'm always going to ask you for this because it's the only way that you can help me. Okay? Because YouTube loves to see likes. YouTube loves to see comments. And that is the way for them to expose the channel. If they don't see interaction, if they don't see you're sharing the video, they think, this is not good. And they stop promoting our channel. So help us out, okay? So I see some of you answering number two, remove the oxygen tank from the client's bed. Means that there is an oxygen tank on the bed. Number two says remove it. Is there anything wrong there? No. Any metallic jewelry, dentures, metal object, such as an oxygen tank, should be removed from the bed. Remember that an oxygen tank there on the bed, where we are defibrillating, or in this case, cardioverting, can spark and create a fire. So that is a safety hazard. So we need to remove oxygen tank. There's nothing wrong with that. Number three, the nurse turns off the synchronizer switch on the defibrillator. Remember that with today's technology, a defibrillator can do both actions, defibrillation and cardioversion. The only difference is turning the synchronized button on. If it's not turned on and we shock the patient, it's going to defibrillate the patient, not cardiovert. So the synchronized switch needs to be turned on. But it says turns off. That is wrong. I need to follow up in that scenario. And number four, place the defibrillator pad on the upper right and lower left of the chest. As we saw on the image before, that is correct. So I can eliminate that answer. The correct answer is number three. All right. So, thank you for being here. If you need some help with NCLEX preparation, we have created this international membership. Everything's in English here. There's going to be videos on strategies, prioritization, the Next Generation NCLEX. There's going to be about 50-something videos. So it's a very short membership. You can have it for a month, 2 months, or 3 months. You can register by clicking on the description link that I posted already there. Or if you speak Spanish, you're a Latin nurse and you want a membership that is bilingual, Spanish and English. Then we have a gold membership, which there are more than 3 courses there: strategies, content, prioritization strategies, critical thinking. There is more than 170 videos, quality videos. Some videos are like 3 hours, 4 hours. So a lot of information. You can register for a gold membership. I've also posted the link on the description. And if you need to contact our academy, here is the number to contact our academy, the English number and the Spanish number for our Spanish advisor. So thank you for being here. Thank you very much. I hope you've enjoyed today's training. Do not miss our next training. Let me tell you what our next training is going to be about. Give me 1 second. If you really want to know what we're going to talk about next, I'll give you a heads up of what's going to be our next trainings. So tomorrow we're going to talk about fluid balance. Okay? Very, very, very interesting live training. If you are confused on fluid balance, osmosis, diffusion, facilitated diffusion, the different fluid compartments, you really need to know this to understand conditions such as, let's say, syndrome of inappropriate antidiuretic hormone, diabetes insipidus, to understand why a patient with diabetes mellitus have a polyuria. Very interesting live training tomorrow. Do not miss that opportunity. Then next week, we're going to be discussing on Wednesday hypovolemia. We're going to be discussing a case on hypovolemia. Then hypervolemia. Then we're going to do hypertensive crisis. So that's going to be the 3 trainings for next week. We're going to do fluid balance, hypovolemia, and hypervolemia scenario. Okay? So if you're happy with the training I am providing here, if you are happy with what we're doing in our YouTube channel, make sure you hit the like button, comment in our comment section, share this with other nurses out there, and that's pretty much it. Do you have any questions? I usually don't stay too much to answer questions, but if you have a question, I'll stay here a few more minutes to answer any questions. Let me see. Mustafa, I have called and no answer. Have you left a text message? Sometimes, you know, our advisor is busy, or maybe you called at a time that my advisor is not working. If you can, leave a text message saying, I called a few times, please call me back, and we'll be more than glad to call you back. And if my advisor don't call you, I'll call you myself. Okay? The next training will be tomorrow. We're going to do a training tomorrow. Olive, new here. I'm really liking what you're doing. Thank you, Olive. Welcome. Welcome to NCLEX Crusade International. Can we do next generation NCLEX style questions? We will. We will be doing a lot of that. Make sure, Elsie, and make sure you've seen our 7-day training on the next generation. Okay? Find it in our YouTube channel, NCLEX Crusade International. Find the 7-day training that says Next Generation NCLEX. I covered a lot of good information on the next gen. What is decreased cardiac output? Okay, it's an important question. You should know what a decreased cardiac output is. Remember, you're facing a nursing exam. You need to recall your anatomy and physiology times to be able to answer this question, okay? But a decreased cardiac output means that the volume of blood that is being ejected from the ventricle, from the left ventricle, is decreased. So basically, what's going to be the clinical manifestations of a patient with decreased cardiac output? Well, basically, we're going to see patient having a hypoxemia. There's not enough oxygen going to the tissues. We're going to see a decrease blood volume. We're going to see hypotension. We're going to see all the clinical manifestation associated with hypotension, up to even neurological changes. Okay, we can see the diminish in the strength of pulses, especially peripheral pulses. So that's basically what decreased cardiac output is. Okay. I see somebody here. Thank you for your hints. I passed my NCLEX exam easily. Congratulations. Very good. Alzbeta, can you repeat about the switch on and off? Yes. So Alzbeta, basically what I was talking was that the main difference between synchronized cardioversion and defibrillation is the synchronized button. There is a button that when you turn it on, it switches from defibrillation mode to cardioversion mode. If that synchronized button is not turned on, basically, if you shock the patient, you're not cardioverting the patient. You will be defibrillating the patient. What's the difference? Well, you know now. The reason for a synchronized button is for the equipment to synchronize with the R wave, with the QRS complex. That way, when you do the cardioversion, the electrical current is not going on top of the T wave, it's more going with the R wave to prevent the R on T phenomenon. Okay, thank you, Dalia. Very good. Remember, you have to go back. I know sometimes it's as difficult. Maybe some of you did nursing school many years ago, and you've forgotten some of those basic concepts. I understand that, okay? Not judging. I know it is hard, a lot of information, but we have to go back to the beginning. We have to go back to the foundation. That is why I'm taking my time in every one of these lives to share some content with you. Even share some anatomy and physiology, okay? Because I know it is easy to forget. Okay? Okie dokie. Well, that is it.